Wonderful. Good morning, everybody, and welcome to our weekly webinars. Colleagues, a reminder that this webinar is brought to you by the Vaccine Advocacy Resource Group, which is 100% funded by advocates, and the African Alliance, with the support from the South African Medical Research Council and the Department of Science and Innovation. These webinars are brought to you in partnership with the Community Constituency COVID-19 Front, the Treatment Action Campaign, and APHA every Thursday at 10 a.m. South African time to bridge the gap between civil society and researchers, donors, and stakeholders that seek to answer some of the most pressing issues of our time during this pandemic. Colleagues, today we speak to Dr. Zewdu. He's the Deputy Director for the Africa Office of the Bill and Melinda Gates Foundation, where he shapes continental health, nutrition, disease eradication, and development investments. Prior to moving to the Continental platform, he served as a Deputy Director in Ethiopia, where he has created significant opportunities for system-based investments built on concurrently identifying, planning, and aligning the Foundation's priorities with the government of Ethiopia's health system transformation plan and the donor community. Given his background in emergency planning and response, Dr. Zewdu also serves as the Bill and Melinda Gates Foundation COVID-19 coordinator for the African continent to inform the shaping of critical COVID-19 and related investments on the continent. We are also joined today by Dr. Zameer Brey, who has worked in senior leadership positions where his core role was that of change agent and turnaround specialist. Currently, he is the TB program lead in South Africa for the Bill and Melinda Gates Foundation, part of the global health team. He has previously served as the acting general manager of the South African Medical Association, process analyst for the Western Cape Department of Health, as an internal consultant to the deanery of the Faculty of Health Scientists at UCT, and has been involved in consulting with the National Departments of Health and Higher Education Ministries. His expertise centers on improving efficiency, quality, and leveraging innovation to drive patient-centered approaches. Colleagues, today, before we begin, we would like to recognize a key moment in the lifetime of the foundation, and that is the passing of William H. Gates II, a lawyer and philanthropist who was the father of Bill Gates, who passed on peacefully at the age of 94 on Monday in Washington state. He has largely been credited with a deep commitment to social and economic equity and for being responsible for the Bill and Melinda Gates Foundation's first efforts to improve global health. This is in addition to his work around taxation on the wealthy. We send our condolences and our thoughts to the wider Gates family at this time as you celebrate a life well lived. Colleagues, we're going to start by hearing from Dr. Zewdu, who will really set the agenda in terms of what the foundation is doing in general globally and more specifically in Africa around COVID-19. We'll then move straight ahead to Dr. Brey, who will hone in on the specific work that the foundation is doing in South Africa, both initiated and led by themselves and in partnerships with their local stakeholders. So the structure of the calls, to remind participants and colleagues, is that the first half an hour we'll get these overview comments. Feel free to put your comments, suggestions, questions in the chat box, and we will ensure we get to those in the last 30 minutes of the call. So thank you again, Dr. Zewdu and Dr. Brey, for making the time to join us this morning, and we look forward to a great engagement. Over to you.
Thank you, Tian. Participants, honored to be here. Completely appreciate the fact that we have this opportunity to talk about a very critical type of subject and an opportunity to learn from you as much as we can share some of our knowledge and realities. Before I get started, I just wanted to echo Tian's sentiment on the loss, the massive loss that we've had in the foundation in reference to Mr. Bill Gates Sr., who happens to be the individual that actually put the foundation together before his son and his wife became co-chairs and started running the foundation. So if it wasn't for him, practically I wouldn't be here, Zameer wouldn't be here, and we would be facilitating this conversation. So we have a huge loss and a great humanitarian with a big heart that matches the big size that he had. So just our condolences also go to the family, and I just wanted to recognize that from the start. My task today is to actually go ahead and give you a broad overview about where we stand and how we got involved in the COVID response from a global standpoint, as well as to specifically what it is that we do on the continent. As Tian mentioned, I am the COVID coordinator for the Bill and Melinda Gates Foundation for the continent, all 55 member states. And we extensively leverage all of the intermediaries and the great power that exists on the continent to make sure that we deliver on needs that are context specific and not necessarily just what we feel is appropriate for the continent. So that being said, I just wanted to start up with for the next 15 minutes or so that I have for clarification points. I just wanted to start with the original conversation around, what is the Bill and Melinda Gates Foundation interested in, and how we kind of structured in a sense of that kind of makes sense to you as we go deeper into the conversations. The foundation is actually divided into divisions. We have a division of global health, a division of global development, a division of policy advocacy and communications, and then we have growth and opportunities. And we also have divisions for that also manage financial services for the poor and financial matters, which comprises the entire one BMGF Foundation. Primarily, we invest in health and nutrition and agriculture, and overall, the intent is to impact or alleviate poverty as a whole. That stems from the core principles that we feel like in our slogan on all of the Bill and Melinda Gates communications, as you would see. Those very core principles is that all lives have got equal values, and everyone should have the opportunity to have a healthy and productive life. Along those lines, when I kind of zoom in on the COVID response specifically, which is the topic of conversation today, very early on, we realized that based on the work that we do around the globe, as well as in Africa and specifically in lower to middle income countries, witnessing the devastation that was taking place in China, as well as the rest of the world, the US, Europe, when COVID hit and we were seeing such massive infections and casualties, we felt like we should be very intentional about engaging the lower to middle income countries, mostly Africa and Southeast Asia, in order to mitigate any such impacts on the continent. So as such, we went ahead and organized ourselves in 2 phases so far, and we're anticipating a 3rd phase of engagement with Africa and Southeast Asia. But our first engagement with COVID was based on the 3 pillars specifically. Those pillars were based on our core principle or our core, COVID-19 mission, which basically stated that we wanted to accelerate the global efforts to end the coronavirus epidemic / pandemic by deploying foundation resources to rapidly strengthen global detection and containment efforts, protect at-risk populations in Africa and South Asia or Southeast Asia, like I said, and also assist in the development of vaccines, treatments, and diagnostics for a sustainable or sustained response moving forward. Under that phase 1, we had 3 pillars, as I mentioned earlier on. The first pillar was to accelerate detection and containment. The second pillar was protecting the most vulnerable, and the third pillar was the development of products for sustainable responses. To just give you some examples on what we meant by accelerating detection and containment, it was about making sure that we fill gaps and inform global responses through partners and existing capacity for rapid action. For example, when we started this initiative and we engaged Africa CDC as one of our intermediaries, we realized that early on during the epidemic, when everybody was out there diagnosing and making sure that they understood their infectivity percentage or numbers, we particularly realized that Africa only had 1 or 2 countries that had the potential to even diagnose. Now, one was South Africa, the other one was Senegal. So the rush to actually develop the capacity for diagnostic and be able to test on the continent as opposed to outsourcing testing capacity and understanding our numbers and our infectivity rate like we do for other diseases in the past wasn't something that we're going to be tolerating on this one as well. So a massive, effort was put together by the Africa CDC, the WHO, APHA, WAHO, national CDCs in country, in the various countries to come together to develop the capacity to test. And the great impact of that is within a single month, this whole collaboration that came together, that we had and that we hoped that we catalyzed, went ahead and created the capacity to diagnose and be able to test and get our own numbers within a month, within 40 countries on the continent, with the rest that were networked. We felt like that was one of the biggest investments and one of the most remarkable investments that we could have talked about in phase one. But we didn't just stop into that. Under our pillar of protecting the most vulnerable, we wanted to go ahead and seek intermediaries, like I said, Africa CDC, or other partners and intermediaries on the continent, which brings us to this conversation: civil service organizations. But basically, we realized that the task was so big that unless everybody was involved, we wouldn't be able to weather what was coming towards the continent. So that was, coming together to make sure that we actually protected the most vulnerable, starting from the elderly, the healthcare workers, and everybody else that was impacted by this disease. Third but not least, we went ahead and talked about, this is a long-term effect. I mean, we have to start aligning ourselves on the upstream R&D development portion of this, which meant, therapeutics, vaccines, and the topic of conversation today as well. So product development became big. Diagnostics were also big. We realized that PCR testing on the continent was meager at best, and it was mostly supported by PEPFAR legacy machines that existed on the continent that we had to repurpose. And even those were not meeting the expectations, because you can't move a massive PCR machine into rural Ethiopia or Senegal or any country on the continent and be able to bring about the impact that the rest of the developed world was bringing in appreciating the epidemic. So those are the three things that the three pillars that we tackled on since, and I won't go into too much details, and I'll leave it for the conversation portion of it, so I have 3 more minutes to go. But since then, we've realized that COVID was not just a disease, an epidemic. It had massive socioeconomic impacts. So in our phase 2 investments and our phase 2 deployment portion of it, what we went ahead and put together is one more pillar in our phase 2 that actually looked at minimizing societal and economic impact on the continent, both in Africa as well as in South Asia. South Asian countries were a little more, we're talking about India, which has got a little bit more capacity than the countries on the African continent. So that was the additional thing that we added in phase 2, which we're in currently, and we're really thinking about phase 3 moving forward, in which I think therapeutics and vaccines will play a much bigger role. Hence the timeliness of this conversation, and thanking Thean for actually reaching out to us and organizing this for us to be able to have a very candid conversation moving forward, because the task is massive, and we need everybody to actually rally around what is the right thing to do and the right way to get it done. So let me pause here, Thean, if that's okay with you, and I'll be more than happy to take answers, but pass it over to my colleague Zameer, or pass it back to you, Thean.
Absolutely fine. Thank you so much, Dr. It's really been interesting to hear, especially around your experiences around testing and the rapid upscale of that. I think that's a very clear example of some of the strategic investments that the foundation is moving for, and certainly a lot of questions that have also been pre-submitted that we'll get to. But without taking any of Dr. Brey's time, I'll hand over to you, Dr. Brey, to specifically speak about what are we doing in South Africa? Who are our partners? What does the investment look like? Any early successes and challenges? And yeah, over to you. I think you're on mute, Dr. Brey.
There we go. Can you hear me?
Yes, loud and clear. Thank you.
Okay. Thanks, Tian. Thank you, comrades, for the invitation to this discussion. We really appreciate that. And just a shout out, because there actually are some comrades here who I know. So very good to connect with you after some time. So Tian, I think that maybe if I can also just talk a little bit about kind of foundation's work in South Africa, which is quite unique compared to some of the other geographies we focus on as the Gates Foundation. In fact, in South Africa, in many ways, represents almost a unique opportunity in terms of doing research and development. So much so that 2/3 of our current portfolio is in fact focused towards R&D across a broad spectrum of portfolios, including health, sanitation, financial services, and interestingly, agriculture. And a lot of the innovations that are done for South Africa, but a number are in fact for the continent and the broader global community. And so it's, in many ways, South Africa is positioned to serve South Africa, but also South Africa for the world. And there are a couple of things that make South Africa particularly important as a country that can deliver on R&D. So firstly, there's very strong scientific and academic capacity on our shores. There's good research infrastructure. We have, not something we necessarily want to be in the top 4, but we do have high burdens of diseases like HIV, like TB, like diabetes, etc. But there are also a couple of other really important enablers of why R&D in South Africa makes so much sense. The government commitment to introduce new tools means that we also have a way to make sure that the tools that we develop are context specific, really take into account the environment in which we're operating in. And in many ways, I think a key kind of enabler for the R&D development and introduction work in South Africa has been a engaged and energized civil society. And we've seen that come through in very tangible ways in our work before COVID, when it came to the introduction of, for example, bedaquiline, delaminid, gene expert, urine lamb, TLD, there's a long list of where civil society has actually played a very catalytic role in making sure that new tools do actually start being used in South Africa. And that has often led the normative organizations to then change policy and direction, which has been great. So currently, the areas we have deep investments in are HIV, tuberculosis, pneumonia, agriculture, financial services, and sanitation. We work with a broad set of partners to be able to bring this work to bear. And without those partnerships, in fact, the foundation would not achieve the successes that it has to date. And so with many of the universities in the country, UCT, Stellenbosch, WITS, KZN, Pretoria, etc. Also the MRC is a key partner, the HSRC. And then a number of implementing partners that have deep experience in doing R&D and product introduction. And of course, civil society as an important cog of this ecosystem. I would say that in terms of, there are a couple of areas like HIV and TB where the foundation has taken a very conscious and calculated kind of view on trying to support end-to-end work. So we do some work in discovery for HIV, development, and in fact delivery. And part of that realization is that we actually do need to support government to be able to introduce the new tools. And it doesn't really, make sense to just focus on those tools development. I think we've seen there's a long history of tools being developed, but not really taking into account the patient perspective, the government context, the policy environment, the ability to pay, etc. And so we feel like for some key priority areas, like TB and HIV, it does make sense to have a much broader perspective on that. And so we work closely with other partners in the country to be able to give effect to those strategies. I would say that quite specifically to the work in South Africa related to COVID, there's a few things that are worth mentioning, Ian and comrades, that the Gates Foundation has lent its support to. So in terms of the data systems work, some of the prior work that we've been able to do that has come to the fore during this COVID period is the work on data systems. And we know that this has been an area of great challenge to date. And so about 3 years ago, the National Department reached out and requested some support to roll out this unique health identifier. And what that really is it's the key to be able to connect patients' data all along their journeys. So this is a project born out of the CSIR, held by the National Department of Health, and actually a great innovation. And to date, we understand that the Department of Health have been able to enroll 40 million South Africans using this unique identifier. Now that also becomes really relevant in the context of a COVID or pandemic response, the ability to understand people's risk for severe disease, to ensure that those that get tested, that they get a result. And we've seen some great innovation in that space as well. So we've supported the Indian people on here, maybe familiar with the COVID line, for example. And it's been great to see that the COVID line has enrolled 7 million South Africans as a source of information and updates on the epidemic, latest news, etc. More interestingly, is that more than 2 million South Africans have electronically screened themselves for COVID. Now, the reason this is an interesting approach is it's a patient-centric approach in that it doesn't require the patient to travel to a facility to get screened. In many instances, it costs the patient absolutely nothing. It was made available on WhatsApp. It was also made available on USSD, the basic feature phone technology. And the uptake has been exemplary. And we are looking at, in fact, making those kinds of tools available for other priority diseases like tuberculosis and in other countries. Another project we are working on, which again is trying to take a much more patient-centered view in the COVID period, is the opportunity to use self-swabbing. So can we actually take the tools that are needed to test patients to where patients are, rather than expecting patients in the difficult circumstances to come into our facilities? We know that there's been fear, there's been stigmatization, all of which are quite substantive issues in forcing patients that need to be tested to come into care. Another kind of key project that we have been working on is how to ensure that those patients that are on chronic medication actually continue to get the medication. This work was informed by the HSRC survey that said that basically 1 in 5 South Africans struggle to access their treatment, the chronic treatment, during the lockdown. And we know that, in fact, those people, based on the global evidence, are at highest risk for severe disease and death. And so a project that we worked on with community healthcare workers and with some of the e-hailing services like Uber and Bolt, etc., was to get patients their medications delivered to their home. A project that was started in the Cape, but has since moved to Buffalo City, eThekwini, Tshwane, and has been able to deliver more than 600,000 packages of medication to date. We think it's an interesting model. There's been exceptionally positive feedback from patients to date, and we hope that, in fact, the model provides some hope or some support and evidence that government will continue to kind of build out these patient-centric models going forward. I think two other areas that I'll just highlight where the foundation is leaning in quite heavily. One relates to understanding the epidemic trajectory in South Africa. And so doing detailed surveillance studies. We've seen the early study that came out of the Western Cape, which showed significantly higher than anticipated seroprevalence positivity of 37%. We know that that was there were significant kind of biases in the sample, but needless to say, there's a need to understand how the epidemic is kind of maturing and moving across the country. So we're supporting the Gauteng province to do a very detailed surveillance study down to sub-district level. We are supporting the NICD to do this in hospitals and specifically focusing on comorbidities, because we know that our population with HIV and with TB are especially at high risk. And so we want to understand that interaction. And then we're also looking at in high density settings and informal settlements, how transmission is actually occurring. And so there's a study with Prof. Madi's group to unpack that more. And then the last study, or last piece of work that we're supporting, and all of the work, just to say, that we're doing over here is in fact with South African-based institutions. The last piece of work is looking at what are the design principles that was born out of the COVID response that are remarkable, noteworthy, and things that we should really hold on to in a post-COVID era. So the agile decision-making, the transparency of data that enabled a much higher level of accountability, the multi-sectoral approach, the patient-centric approach, the extent to which regulatory enablement, for example, to open up telemedicine, to allow the transport of medications, actually speak to what the country needs and what patients really need and want. And so we have a local group, Matchboxology, that is trying to capture some of these lessons with the hope of sharing that with government. And so those are, Tian, just a few of the investments that we are making, and I look forward to the discussion that will follow. Thank you.
Thank you so much, Dr. Brey, appreciate it. So I think we have a range of questions. I'll invite both Dr. Brey and Dr. Zewdu to feel free to tackle any of the questions that they see are relevant in their particular portfolios. I think an overarching question, and I know certainly groups like the Vaccine Advocacy Resource Group and the African Alliance and some of our partners had some early discussions with the foundation around this particular issue, and I think it's important, to address this upfront so we can move on to some of the other questions. But this, certainly for those of us who have been in the vaccine advocacy space for quite some time now, saw a very visible, almost tangible increase, almost an explosion of anti-vaxxer, anti-research messaging. Along with that, of course, came a lot of really highly personalized individual attacks on Bill and Melinda Gates. And I guess as a collective, we're really interested to hear your thoughts on how is the foundation managing it. Some of the initial feedback we've gotten from the foundation is that you're managing it through your comm strategy, but the reality to a lot of us on the ground is we aren't seeing this, these issues being addressed. So part of the work that we've been doing is we've been tracking anti-vaxxer sentiments amongst political leadership, and there's a constant flow of anti-vaxxer, anti-Gates sentiment that is really, in my mind, goes beyond just the work of the foundation. It sets back an entire sector because it plants seeds of confusion and doubt, and it really impacts how we can then target potential anti-vaxxers who might be sitting on the fence. It almost pushes them over to the other side. What has your experience been, so perhaps in Africa and then specifically in South Africa, been around responding to this? And of course, we know that there's a group that you will just never be able to engage with and change their point of view because they firmly believe it and that's their right. But what work have you been doing to at least more aggressively or strategically deal with this movement of hatred, misinformation, that is specifically and meaningfully impacting our ability as advocates to get on with the important work of supporting and creating communities that are excited about research, but also understand and begin to take ownership of research that is happening in their communities? And anyone can, oh, I see Solomon appears to be muted. There you go. Is it working now?
Yes, thank you. Yeah. It keeps locking me out every time I have to request to be unmuted. So again, a tremendously important question. As you know, and you preface this by saying that you've already talked to our communications people, and we do have a pretty robust communications team that actually follows these disinformation and misinformation, which seems to have increased, like you said, over the past few months. That, you know, and the overall strategy is, as far as I know it from my position, and there's also additional conversation that needs to take place with the folks that are tasked to actually manage this, would be we try and create as much evidence, we try and create as much transparency as we can. And that's the approach. Of course, like you said, there are some people that you cannot potentially reason with, and whatever you do, whatever you say, whatever you present as evidence won't trickle down and won't make an impact. But for those that are slightly confused, those that are really looking to understand why these sentiments and, you know, what is the actual fact out there as opposed to a lot of opinions that get tossed around, our policies to actually make sure that we don't run away from it, but actually present opportunities such as these to be able to come and discuss it openly. There's no secret. There's no secret lab out there that's doing all sorts of crazy stuff. What we do is open. What we produce is open source. It's public good. So to some degree, the idea is to show that there's no ill intent. And if there's any misinterpretation of anything, to our various capacities, you know, and there are people that can articulate this a lot better than I do, some of my bosses, we are available. We don't shy away from engagements. We do not shy away from the misinformation and disinformation that we see, as long as they come within the realm or the parameters of, you know, decency and basically really inquiry. You know, some are ugly and they just don't particularly make sense. So fueling the fire on some of those things that doesn't particularly make it productive. But at the end of the day, our attempt for both myself and Zameer being part of this conversation, despite the fact that it's a very charged environment, and it's about vaccines, and it's about, you know, it's not just about vaccines anymore, it's also about therapeutics and, you know, a general sense of why do you even care? Why would you put all this money in a continent like Africa? What's the grade? What's the interest in there? And I think I saw something in the chat as well, from somebody that posted that. And my answer would be, why not? I mean, this is where the need is the greatest. And my personal opinion again would be, you know, I'd rather have somebody care than not care, because we know what not caring does. So as long as it's done in the right way, as long as it's not imposing particular, interest on an unwelcoming community or unwilling community, and you try to convince them otherwise, as long as you're working in partnership, as long as you can find your champions and your advocates in the space, and you're able to convince them so they can take your agenda as their agenda, and you work in partnership, I think, you know, it's a win-win situation. But the main idea here is we don't run away from it. We don't want to create a void in which things fester and they come out and they become tremendously unrealistic sometimes. But the idea is the evidence is there. We'll generate as much evidence as we can and present them. The transparency should be there. of course, if again, this is a two-way street. If the message is not being communicated in the right way, and there are suggestions on how we can do this better, and this is an amazing group that we can tap into. How can we do it better is a narrative that we continue to have. How does things resonate? How are they made context specific? How do they resonate with the individuals that we're trying to help, and not come on and impose our will on how to do things? Poverty is poverty, illness is illness, treatment is treatment. So there are these principles, but how you engage and how you bring that topic forward and get acceptance is a very nuanced skill. So we're open, we want to communicate completely, be transparent, but also seek your advice on how best we can get this done. And South Africa has got some a tremendous pool of civil society organizations that have massive impact. So this is a place where we can actually really learn from and hopefully catalyze on the rest of the continent and eventually the globe as well. So I'll stop here and maybe yield to Zameer to add anything.
Right.
Sure. Tian, can I add?
Yes, sure.
Is that okay? Yeah. No, I think Solomon, you set me up really well. Comrades, there's actually a report I would want to share with you, Tian, if you allow me to, which is our goalkeepers report, which was just published 3 days ago.
Sure.
And I think there's a statistic in there that just gives me goosebumps. And that statistic is that we stand to lose 25 years of progress in vaccines in 25 weeks. And that's how quickly the world could be, at a threat that is multiple folds bigger than COVID. And in fact, we should bear in mind that the issue of the anti-vax kind of sentiment is not restricted per se to COVID vaccination. What's a very concerning trend, if colleagues haven't seen in South Africa, is that despite lockdown levels decreasing, immunization has not recovered. In the best situations, they are 20% lower than last year. In the worst, which are in some of the metros, we're seeing almost up to 40% reduction in children's immunizations for measles. The reality here is that potentially leads to the risk of massive outbreaks that would compromise the most vulnerable, the youngest in our population. There's also a survey that came out, and I don't know if colleagues saw that, by Ipsos last week, that basically put South Africa in the lowest 10, I believe, in terms of appetite for vaccination. Now, this is not a phenomena that South Africa, or a challenge that the South Africa health system needed to deal with substantively previously. And like you say, there was always a small percentage that were going to not use vaccines for a range of reasons. But that proportion seems to be increasing at quite an alarming rate. And I think that the way we're going to address this head on is to really try our level best to present, as Solomon has alluded to present the data in a transparent way, to provide the evidence in a way that's accessible. And I think that, the point around making sure the data is accessible is really important, because I think that what we should do is we could have, there are a number of very credible voices that have come to the fore. Individuals who have an amazing ability to articulate very complex concepts to the general public. I mean, we've seen, people like Professor Slim Karim, people like Professor, Shabir Madi, really connect with the public in a way, that public health folks haven't really kind of done before. And I think that what we should try and do as a community is cultivate champions who can speak with credibility, but also get voices from communities who can relate to and understand individuals' concerns and translate what that evidence is saying in a way that becomes really accessible for communities. And I think that you described that there are people that are sitting in the middle or sitting on the fence that are waiting for that kind of guidance. And hopefully, you know, they haven't completely kind of blocked off to the idea that, you know, that vaccines are bad, etc. And so I think that what we will need to do as part of this response related to COVID, but I think it's a broader issue around vaccines, is to connect with local organizations who really have a deep understanding of why this anti-vax sentiment has come about, why it's growing, and how to stymie that. And so in some ways, Tian, it's almost an answer. I think Solomon and I are looking to this group to help us unpack, because I think you probably have a better understanding of, you know, what some of those challenges are.
Mm-hmm. Yeah, thanks for that. I think, I mean, one of the issues certainly is that, like you say, you know, it's not just confined to COVID. I mean, these are issues we faced with HIV vaccine trials, a lot of the TB work as well. So we really feel that it is important to almost amp up that kind of investment in groups and community groups who can then take these complex concepts to critical mass. And of course, we do a lot of work with social media influencers and work on social media to ensure that the very critical concepts are communicated. Another common thread in the questions here is the understanding or the perception within civil society that the foundation is particularly excited about investing in African groups and movements. And however, this is usually done, according to some of the comments in the group, via international NGOs or via the North. So you would find groups in Africa being funded via Zurich or via an NGO in New York, et cetera, et cetera. Could you perhaps share some of your thoughts on the foundation's political principles of directly investing in local organizations and not necessarily having that funding go through organizations in the global North? Is there, I imagine there's a thinking behind that, if that is indeed the case, but I will give you the space to respond to those comments which were submitted by both Yvette and Yumna.
So, yes, Tian, I mean, this is a great example of our own evolution and our maturity process. As you can imagine, the foundation is 15 years old. In comparison to organizations that have been around for quite some time, we're still an adolescent, making a lot of mistakes and still learning. There is an intentional movement in our strategy to actually start really looking at how do we build continental capacity to actually take on some of these works that were being done by international NGOs. It's not a light switch, as you can imagine. We can't just say, okay, you know, a few months ago we had all these international NGOs that were in the space, you know, moving and shaking things, but now we want to make sure that we shift it over. It goes through a whole process of actually trying to understand who do we pick, who do we align with, how do we bring organizations on board through our own, you know, limitations as well as a public, as a foundation. There has to be some rules and regulations by which we engage in civil societies or private sector or governments and things like that. So just to let you know that, yes, you know, you're absolutely right. You know, international NGOs have dominated the space, and it felt like sometimes, you know, depending on how well the international NGO is actually managed, it feels even in an imposition as opposed to an assistance. You know, you can continuously swimming against the tide. They come with money, fully funded, and they'll basically come in and try and tell you what's best for you. That has been recognized, and we recognize that quite effectively. And we want to make sure, without really undermining the value of international NGOs, that we continue to actually start striking a balance. To let you know, we are going through our, you know, Africa strategy development process right now. We are a young office, so we're beefing up our presence on the continent. And one of the major things that we are tackling right now is how do we do not just partnership and capacity or getting the work done, but actually how do we actually build the capacity on the continent? What is it that we need to do, and how do we need to design differently in order to make sure that we harness the existing capacity on the continent in everything, in development and in implementation, in R&D, in institutions that are homegrown as well as continentally grown. So this is work in progress, and it's a very good reflection of our own maturity phase. We're starting to understand that we need to get closer to the problem that we're trying to solve, and we need to use local solutions in order to actually bring about the change that we want. And once we get those things in place, we do understand that we'll be able to move the needle a lot faster than we were able to do it in the past. Some of these resentments about vaccine and things like that, I'm assuming that if the vaccine was done in your backyard and you knew about the process from start to end, you will have a lot less resistance when it's deployed out, as opposed to being done somewhere in the north where you have no concept on how it was developed, who it was developed on, and how it ended up coming in your backyard and it's trying to immunize your children or the adults for the COVID state. But we're very much cognizant that we want to make sure that we start tapping into the continental capacity where it's there, leverage it. Where it's not there, try and build it.
Yeah. Thierry, if I can just add and kind of build on, some of that, I think that a very focused attempt that we're undertaking is actually tracking the funding flows from the foundation perspective. And so it's not something that was traditionally looked at, but with the Africa team formation and our current leadership with Umar, Solomon, and others, is actually making sure that we can follow the dollars that leave the foundation. And so often what was happening previously is that even the dollars that were landing on the continent were then being diverted back to northern institutions. And so that's a metric that we are, increasingly looking at. And they are obviously, as Solomon says, this is going to be a journey of making sure that we try and move more and more investments where appropriate to be made on the continent for all of the reasons that were listed, previously. I think another metric that we are looking at is making sure that we are a lot more cognizant around diversity, equity and inclusion when we make these investments, whether that's gender or race. And I think this is also part of the foundation's own kind of journey to make sure that we're more intentional in that regard. With the COVID response, Tian, I can say that for the South Africa response, in fact, all the South Africa specific investments are with local institutions. And there was, a couple of these investments where there were multinational organizations that we considered, but are pleased to say that, we've been able to go the route of investing locally. And I think that I want to give two examples. The one is about 2 or 3 years back, there was a project that the Africa team undertook to actually say that there are few partners that are so important to our overall strategy as the foundation. And we see ourselves working with them long-term, etc., that we need to invest in building their capacity. And we were quite fortunate that 2 of the organizations were based in South Africa. In fact, I think it was the Treatment Action Campaign and the Aurum Institute at the time. And what was nice about those investments is they didn't have a specific investment outcome, like, do this trial, etc., but rather, what do you need as an organization to build your organization for sustainability? And so it was giving some flexibility, to the organization to be able to do that. And my understanding and kind of feedback on that those investments were particularly well received. Now, you know, it's not a common investment for us to make, but just to say, I think there is, you know, some precedence in us recognizing that. I think the last example I just want to share with the colleagues here, and I do see Melinda is on from the Boland Community Advisory Board, and she'll know that, in fact, SATV, the South Africa TB Vaccine Initiative, was set up with significant funding from the Gates Foundation, has world-class research infrastructure to be able to test and do research on TB vaccines, so much so that probably at least 2 in every 3 vaccines globally get tested through this site. But what was, I think, particularly noteworthy about this is that the investment, the science, the engagement with the community, the buy-in from government meant that this became a national asset and actually attracted significant more investment from other donors to invest in this, you know, kind of world-class capacity in a way. And so the dependency on the Gates Foundation, you know, really kind of waned over time. And I think it's a good example of a initial investment that then becomes sustainable beyond, you know, that kind of seed funding period. And we have the confidence that there are going to be many, many more examples that come from the continent of this kind of investment.
Yeah, thanks for that. I mean, I think, so the usual standard of these calls is that once we're done, there will be questions that we feel have not yet been fully addressed, and so we'll be in touch with yourselves and your team to flesh those out a bit more, to get feedback back to our various partners. But I mean, I think in terms of reflecting on what Dr. Zewdu was saying, our limited experience with the foundation has certainly been one of openness. We've never received a sorry, we can't engage email, or not right now. Certainly with Natalie and the rest of the team, it's been a very clear willingness to engage. And I guess as our relationship grows and strengthens, we'd be in an increasingly better space to tackle some of the more difficult questions. But in closing, I just wanted to get your thoughts on, do you feel that the levels of historical investment in the health space, has COVID been a distraction, and has COVID taken away attention, in your view, from what Melinda is also raising, you know, access to HIV, access to TB? I know you touched on it briefly in terms of access, but after COVID, do you think we'd be in a better, and even just saying after COVID sounds ridiculous at this stage in life, but once we've adapted to a world where COVID exists and it is part of our reality, do you believe that the investments that we're making now in terms of the COVID response will further strengthen the research sector in general, as we almost hopefully fall back into people accessing treatment, prevention options, care, et cetera, at a very local level? And then the last question before we wrap up is, could you specifically speak to your experience then with TAC and ORM, in terms of, you almost stepped out of the traditional donor partner box and you said, you all give us direction in terms of how you want this investment to roll out. And once you did that, at the end of the day, I'm imagining now it's quite a while after the fact. What has the takeaway been, and has that impacted how you granted going forth? Or was that an interesting experience and you kind of fell back into, you know, normal practices of grant making, where the agenda is pretty much set and the terms of work are set and people bid, et cetera, et cetera? So the two questions: do you think COVID has been a damaging distraction as we move on into level 1 and perhaps no level at all? And then secondly, has your experience with TAC and ORM materially impacted the way you grant thereafter?
Both very important questions and highly critical. Yes, has COVID been damaging? It has. It took all of our attention away, and we chased about a disease that particularly made us feel like if we tackled that one, all the other problems that we had were just going to stand there and wait for us, which is an unfortunate way of thinking of it, and how we got so distracted and why we went all out on COVID will be, topic of discussion to move forward for many years to come. But it has been a distraction and has been damaging. And the whole discussion about how do we make sure that whatever has happened, compromising your economy, compromising your routine services, the TB inference in the chat, definitely. And there has been some robust conversations along the line of saying, when you're in the response space, usually there's these slogans that you use, or these quotations that you use, rebuild better, dual purpose investment and things like that. So we've been talking about these for months now, and all over the continent, and I have the opportunity to kind of look across 55 member states and look at all of the agencies that are on the continent and have these dialogues, from the AU to Africa CDC to WAHO to WITS University, all of these think tanks and all of these decision makers that are out there. And we have been cognizant, but we're also caught into this COVID frenzy, rightfully so, because it was a massive killer. We've never seen a pandemic before. None of us, even I'm probably senior in this group, haven't seen a pandemic, because the last one was in 1918, and it was 100 years ago, and none of us knew how to handle this. So we went all out with the way we knew how to best do it, which was, just go ahead and tackle it and contain it. Was it containable? The jury's still out, because it's all over the place now. What did we drop in the process of chasing after COVID? Maternal child health, neonatal and newborn health, TB, malaria, HIV, you name it. Everything that we were tackling for decades under the MDGs were put on the back burner, rightfully so, because we had a much bigger thing to deal with. But midstream, about a few months back, everybody started realizing that this is COVID, like you said, Tian, is here to stay. I mean, vaccine will come, and will take at least a couple of years to get to potentially, herd immunity even after vaccine. So it will be in the background. I think the new reality will have COVID in the background. My 8-year-old daughter talks about, I was born and I survived the era of COVID. So it's become part of our existence. So that, for me, was a distractive factor, and rightfully so. We all went all out. But now, how do we recover back from that? And we minimize the damage on other situations. The TB treatment that is falling, the HIV treatment that is falling, the maternal child health, the neonatal mortality rates that are climbing. How do we go back to making sure that we bring those as a priority? Because one thing that's unique for the lower to middle income countries, Africa and South Asia, is that we are tackling multiple things at the same time. When you look at the North, basically, there's no malaria to worry about. There's no cholera to worry about. Measles, of course, because of, immunization, anti-vax movements can actually flare up. But there are all these old foes that we know exist on the continent and will not, fade away because we're tackling COVID by itself. So right now, it's a balancing act that we have to go through. And one of those vulnerable things in there as well is not just diseases, but it's also our economy. So we have to go back and make sure that we don't, unemployment rate has gone up all over the continent, and we were on lockdown and things like that. So the impact of COVID needs to be better appreciated and better managed as we move forward. So the long answer to your very crisp question was, yes, it has been disruptive, and it has come at an expense. About grant making moving forward, your second question. The grant making forward, we won't go back from the processes that we learned. We learned these lessons because there was a need to learn them. And moving forward, our investments are really looking at this new way of doing business, this new way of actually bringing impact on the continent and the places that we want to bring impact globally, or the programs that we want to bring impact globally on. So we won't go back. This journey will take us to one of the slogans, building better. That will put us in that position where we kind of start thinking about, we wouldn't be in the predicament that we are with COVID if we had planned differently, if we had invested in health systems more robustly, if we had invested on local capacity more robustly. There wouldn't be that massive frenzy where we'd really be scared about the massive infection rates and the massive death counts that that really drove our impulsiveness to actually really tackle COVID and kind of almost put everything else on the back burner. We can't afford to do that again. So moving forward, it's my personal belief, and as we build our presence on the continent, and we also increase our bandwidth to actually engage and be more proactive, I think more of the how do we do this together? How do we get solution locally? How do we get solutions from the people that are actually living the issue, breathing the issue, sleeping the issue, is the way we're going to engage. And I think I find myself, well positioned to be able to make that statement, because I am part of the team that actually comes up with the strategies and the planning process as well. So that would be my feedback to you.
Thank you, and I think it's a wonderful way to end. Dr. Brey, any final remarks, comments in the 60 seconds that we have left?
I would just say that, I would concur fully with what Solomon has said around that we've taken a hit. The health system has taken a big hit around COVID. I will say that I think there's a very specific role for civil society to play in trying to extract what has happened and has worked from a health system perspective and keep those in place. So how did we get, very rapid regulatory approvals on some of the products? How did we get, the space to open up for telehealth? How did we get, some of those relaxation of the pharmaceutical guidelines, which looking back, we should wonder, were they necessary to start with? But I will say I feel like that window is starting to close. And so if there isn't a voice and advocacy around making sure that those things stay in place, I would say that not only did the health system and these priority diseases take a knock, but we also lost what was beneficial to the health service overall. And just to thank the colleagues here for a fantastic discussion. I've certainly learned a lot, and apologies that we didn't get through all of the questions. I guess a sign of a robust debate. And we look forward to building this relationship. So thanks for the opportunity.
No worries, absolutely. And this is certainly not the last time you will be hearing from us. I think as you were both speaking, and thank you for great comments throughout, and thank you participants for really engaging questions. The issue of the World Cup kept on coming up into my mind in terms of the losses that we saw after the World Cup, especially when it came to sexual and gender-based violence. We set up these emergency response courts immediately, and in some areas you've never seen that rapid uptake of justice. We've never seen it in South Africa, at least in the 20 years I've been doing this. And after the World Cup, those courts were shut down. And I think in my mind, that's a very real comparator to say we've been here before. Except of course the World Cup in theory was a happier space. But we've been here before, and we've seen that when we galvanize the political incentives to put in place the structures and the services that we are constitutionally entitled to, like you say, a large amount of work has to happen by civil society to protect those gains, to ensure that they're not lost with or without COVID, because I believe there will be another pandemic. It's not our last pandemic. And so we need to leave this pandemic in a better place than before. Dr. Zewdu?
May I put a plug in? I mean, I wanted to say that, hold us accountable. We all work in service of the vulnerable. And there was a question in there that said, what do you mean by vulnerable? Unless we are true to what we're trying to change and we're held accountable and we're being challenged, we won't accomplish what we set out to do. So before it gets to the point where it becomes misinformation, disinformation, and antagonistic, and help us be our eyes and ears and our counsel telling us, you're really going the wrong path here. You might be thinking that you're going goodwill here, but you're not being accepted. You're not being received well. So only when this two-way street is generated, we will feel like we really reached the community, we really reached and we made an impact, because our work is shifting more and more and more. Our way of thinking, it's no longer a theory of change and upstream designing. It's about impact and working our way back. Our CEO tells us all the time, what impact do you want to bring about? I want you to think that way. And the impact is with the country and the community and the people that we want to, benefit. So I just wanted to say that, let's make sure that, when we open these forums of conversation, we don't come in as this big elephant in the room or gorilla. We come in just like anyone else, and we're here to learn, and we're here to receive and to better program, to your second point.
Absolutely, yes. And holding power to account is in our DNA, so we're certainly going to take that up. Again, Dr. Zewdu, thank you. Dr. Zameer Brey from the Bill and Melinda Gates Foundation, thank you so much for joining us, and we look forward to have a great.
Thank you so much, everyone, for taking the time.
Thank you, everyone. See you next week.